morning, good afternoon, and good evening, everyone. My name is Ellen Piwoz, and I'm the moderator for today's launch of a new Lancet series on maternal and child undernutrition, a review of progress and actions to address this unfinished agenda. The new series includes 3 papers covering updates on the burden and epidemiology of undernutrition in low and middle income countries, the efficacy and effectiveness of nutritional interventions, and lessons from delivery of these interventions and other efforts to accelerate progress. There's also a commissioned commentary, which I encourage all to read as well. So to give you a brief overview of today's 2-hour program, the first hour will focus on the findings from the 3 papers with time for discussion and questions and answers at the end. The second hour is a panel discussion with 3 women, all remarkable global leaders, to reflect on the evidence, where we are today, and priorities for the 2021 Year of Action for Nutrition. We will end with closing remarks on the way forward. So now, to kick off today's program, I'm pleased to welcome my longtime friend and colleague, Dr. Robert Black. Dr. Black is a professor of international health and medicine and director of the Institute for International Programs at Johns Hopkins Bloomberg School of Public Health. His research focuses on maternal and child nutrition and the interaction of undernutrition and infectious diseases, with experience conducting trials of vaccines, infectious diseases, micronutrients, and other nutritional interventions. Dr. Black has received many awards over his long career, but I know him as someone who's passionate about the use of evidence in policy and programs. As many know, Dr. Black was the lead author and coordinator for the 2008 and the 2013 Lancet Maternal Child Undernutrition series. Since the current series is an update on progress, we thought it fitting to start off today's launch by reflecting a little on the past. So welcome, Bob. I've got a few questions for you this morning.
Sure, thank you, Ellen.
The 2008 Undernutrition series was a landmark publication that spearheaded many initiatives as well as investment in nutrition. So I've always wondered, Bob, what motivated you and your colleagues to write that series?
Well, in the early 2000s, it was a time of waning interest in programs to support child survival, improve child survival. So some of us proposed a series on the unfinished agenda for child survival as a series in the Lancet, and actually it turned out to be the first series that Lancet published in 2003. This presented information on the causes of child death, including the importance of undernutrition as an underlying cause of death as part of the synergy with infectious diseases. It also presented a limited set of interventions, including 6 for nutrition that were proven to work, feasible to implement, and capable of reducing mortality if scaled up with high and equitable coverage. There was a very positive reaction to the series and in subsequent years, renewed effort on child survival. However, rather than do an update of the series 5 years later, we decided to do instead a series on undernutrition because we thought that was not getting enough attention and support. So we decided to do this series on maternal and child undernutrition for its role in mortality, but also because of the broader consequences for child development, adult health, and human capital.
Wow, that's great. And thinking back on that series, which I'll remind the listeners consisted of 5 papers, what do you think were the 3 or 4 most important findings to come out?
Well, one is we wanted to say, well, what were the major underlying causes of mortality? And the MDGs had only a target for underweight, which was part of the goal on reducing poverty. The series identified wasting, stunting, intrauterine growth restriction as the largest underlying causes of child mortality, and as targets for nutrition programs. The series stressed the importance of maternal undernutrition with consequences for the mother and the baby, and stressed the importance of breastfeeding and complementary feeding in the first 2 years of life. So this led to what has become known as the focus on the 1,000 days from conception to the baby's second birthday. We presented in the series compelling evidence for the importance of this period for both short-term outcomes and adult health outcomes. The series prioritized 8 preventive and 2 therapeutic interventions, nutrition interventions, and estimated the reduction in both death and disability that would happen if they could be scaled up. And we called on the international nutrition system to end fragmentation, improve program guidance, and for the world to increase the funding for nutrition programs.
Thanks. I know that the series had a great deal of impact on the work that the Gates Foundation was doing. I was at the Gates Foundation at the time, as well as the work of many other donors. What were the main responses to the series from your perspective? What stood out to you the most, and did this response meet your expectations?
Well, the series was launched in a number of countries to increase the demand and investment. It was very gratifying that many national stakeholders as well as global stakeholders did take up the call for more action on nutrition. A very specific action was the formation of the Scaling Up Nutrition movement, which built on the series recommendations for prioritized nutrition action for national leadership and also global coordination. Mm. Another action that happened, perhaps related, but certainly independent, the UN developed the WHO, World Health Assembly, global nutrition targets that kept the focus on stunting, wasting, low birth weight, breastfeeding, and maternal anemia, but also added obesity as a concern.
Thanks, Bob. Those were indeed important sequelae to that series. Now let's fast forward to 2013. What were your top takeaways from that set of papers, either in terms of new findings or how those findings got translated into political action and investment?
Right. Our second series was launched at the time of the first Nutrition for Growth Summit in London. And certainly we wanted to reiterate the messages from the previous series that undernutrition was an underlying cause of death and estimated that was an underlying cause of 45% of child deaths. And this was widely quoted at the summit. We also reaffirmed the importance of undernutrition in pregnancy and in early childhood as major contributors to poor growth and development, but also to chronic disease in adults. And the other aspect is for this series, we focused not only on undernutrition, but also added information on the rising levels of overweight and obesity in children and in women of reproductive age. We identified 10 core nutrition-specific interventions to be scaled up. And we also found potential in what we call nutrition-sensitive programs in agriculture, social safety nets, early child development, and education, especially if they included strong nutrition actions and for some focus on women's health. And we highlighted factors to create an enabling environment for nutrition. I would say there have been many developments that have followed this. One, since it was launched at the Nutrition for Growth Summit, I would say one could make a link with the pledges at the summit of $4 billion for nutrition-specific programs and $23 billion for nutrition-sensitive projects. The Sustainable Development Goals were published subsequently, 2015, and these, I'm told, had influence of the series. They included a specific goal on hunger, food security, and nutrition, and also an influence on the specific targets in the SDGs. And then I would just mention the World Bank's investment framework for nutrition that estimated the effect of scaling up the interventions recommended in the series to achieve the World Health Assembly targets, and that would result in 3.7 million fewer deaths and avert stunting in 65 million children. This investment framework called for an additional $7 billion per year for nutrition-specific programs to meet these targets.
Thanks, Bob. And finally, 2021 has been called a year of action and opportunity for nutrition. Very briefly, what do you hope will result from the current series?
Well, I certainly hope we can increase the world's attention to the continuing problem of undernutrition in women and young children, and to the strong and increasing evidence that direct nutrition interventions and intersectoral strategies, if adequately funded and implemented, will reduce mortality, will improve quality of life, and enhance human capital.
Thank you very much, Bob, for joining us today and for all that you've done to elevate global attention to the unfinished undernutrition agenda. Now let's turn to the papers. Before I introduce the first presenter, I want to acknowledge all the authors who contributed to this series. This series represents years of work from colleagues around the world, and it would not have been possible without everyone's contributions. And then for a bit of housekeeping. We want today's launch to be as lively and interactive as possible, but with more than 1,000 people joining, we do have some constraints. So if you all have questions, please use the Q&A function. If you have these questions, co-authors from each of the papers are monitoring the Q&A, and they'll try to answer them directly in real time. And then some of your questions will get elevated to the panel during the designated Q&A period. So moving on, we're delighted to have 3 speakers this morning: Drs. Cesar, Victora, Zulfiqar Bhutta, and Rebecca Heidkamp. Dr. Victora. Dr. Cesar Victora is a renowned epidemiologist and specialist in child health and nutrition. He's an emeritus professor of epidemiology at the Federal University of Pelotas in Brazil, and he holds honorary appointments at Harvard, Oxford, and Johns Hopkins universities. He was president of the International Epidemiological Association from 2011 to 2014. Dr. Victora's work has influenced global policies on breastfeeding and early nutrition for decades. Today, he's one of the leaders of the Countdown to 2030 initiative, which focuses on strengthening country evidence and analytic capacity and monitoring progress toward the health-related sustainable development goals. So Cesar, please go ahead.
Thank you very much, Ellen. Good morning, everyone. It's a real pleasure to be here to speak to you on the first paper in this series. Can I have the slides up, please? Yes, our paper is on revisiting maternal and child nutrition, undernutrition in low and middle income countries, and subtitled is Variable Progress Towards an Unfinished Agenda. And I would like to thank my co-authors who are participating and who have helped a process that has taken about a couple of years to be completed. Next slide, please. Our work has been based on a very broad review of the literature since the last Lancet series in 2013 to see what's new, and also a new analysis of national data for 50 countries with 2 surveys. The first around the year 2000, the second around 2015. Next, please. Yeah, we start with child nutrition. With child nutrition, we show that stunting was reduced, but progress was slow for wasting and low birth weight. On the left side, you'll see the distribution of height for age in children under 5 in the 50 countries we have analyzed. The solid lines are low-income countries, the dashed lines are middle-income countries. The red lines refer to the year 2000 and the blue lines to 2015. The bell-shaped curve, the green curve you see in the middle, is a WHO growth standards, and the black vertical line is the -2 Z-score cutoff, which is traditionally used to measure undernutrition, in this case, stunting, because we're talking about linear growth. The most important finding in this graph is all red and blue curves are shifted to the left. So undernutrition, linear growth faltering is a population problem, not an individual problem. So we shouldn't be only concerned about children below the -2 line, but also about the whole population, which is shifted to the left. There's been some improvement. You see that the blue lines are slightly to the right of the red lines, but you'll see better, you'll be better able to see the improvement in the next slides because this scale in this graph is very tight. It goes from -6 to +6 standard deviations. So the changes are actually larger than they appear to be on this graph. On the right side, we show the concurrence of wasting and stunting in the 50 countries. The green areas are children who are neither stunted nor wasted. The proportion of these children, which do not have either problem, has increased in low-income countries. The second part of the bar, the orange section, are those who are only stunted, and it's also decreased, particularly in low-income countries. The yellow section are children who are only wasted, and there's been no change here. And the red section is the one that really concerns us most, because these children have very high mortality. They are both stunted and wasted, and it's been stable. It's in middle-income countries, showing a little bit of reduction in low-income countries. But if you add the red and the yellow bars, you'll find that wasting has remained stable at 15% in low-income countries, and has slightly increased from 3% to 4% in middle-income countries. Now, the next slide is about linear growth faltering by age. And you've probably seen many of these graphs. These are behind the idea of the importance of first 1,000 days, because we see that children are born already with a deficit, and that accentuates with a faltering period up to about 2 years of age. And after that, they run parallel to the WHO line. The WHO line here is the green line. The same green line you saw in the previous slide is now a flat line at 0, which is the median value of the standard distribution. And there's also a line at -2. So we see there's been improvement in low-income countries with birth length increased and the duration of faltering period was reduced. So children tend to falter for shorter periods of time. There have been similar but less intense patterns in faltering in middle-income countries. But also note that in 2000, middle-income countries were already better than low-income countries were 15 years later in 2015. Now we turn to the right of this slide, and we show that there's been some slight improvement in weight for height, which is related to wasting in low-income countries, but virtually no change in middle-income countries. And also in middle-income countries, these children are growing above the WHO standard, which indicates the growing problem of child obesity in these populations. They have more weight than they should relative to their height. Then the bottom, there's really interesting results. These are one of the highlights of our series, that we have been fortunate to have the KI Child Growth Consortium results that we can review and cite in our paper. These show that the peak incidence of stunting and wasting takes place in the first few months of life, 3 to 6 months, even more acute than we thought in the earlier analysis. And also, they show that children who are both stunted and wasted, those in the red bars in the previous slide, they are 4.8 times more likely to die than those who are neither stunted nor wasted. And the next slide will show some information now regarding, next please, women's nutrition. We find on the left, again, using red for 2000 and blue for 2015, we see that there has been an improvement in low BMI in women. Low BMI representing women's and maternal undernutrition. It was reduced by half over time, although this improvement has been associated with an increase on the other side of the coin, which is overweight in women. There's been very little change in the middle in short height, remembering that our cutoff is very strict. It's 145 centimeters. We know that short height is a major problem in parts of the world like South Asia and Central America. But more importantly, there's been no change in anemia, very, very little change in anemia in women over this period of time. And on the right side of the graph, we have a map, which is the first subnational analysis of hotspots for low BMI in women, where the darker red areas show higher prevalence, and there are lots of hotspots in sub-Saharan Africa and in East Timor. Lots of countries don't have any data, which is a real problem. But if you take the WHO recommendation of target supplementation when prevalence is 20% or more, only India and Bangladesh would qualify at national level, but our data show otherwise. There are lots of districts and provinces in countries where there will be also a public health problem and with low BMI that needs interventions such as targeted supplementation. Now we move to micronutrients. Next, please. And what we find is that these deficiencies remain largely unabated. Vitamin A deficiency has been reduced through supplementation in children, but still affects about half of African children, in South Asian as well. Iodine deficiency has been eradicated in many countries with salt iodizations, but about 25 countries still have a problem with iodine deficiency. Zinc deficiency is largely unabated and present in about over half of African children, and iron deficiency accounts for a large share of anemia burden that also affects about half of children in low and middle income countries. If we turn to women, we have much less data, and that's a real data gap. So we have to rely on individual separate student studies. In Nepal and Bangladesh, about 80% of women had at least 2 micronutrient deficiencies at the outset of pregnancy, particularly vitamins B12 and D, iodine, zinc, folate, and iron. And also there's very scant data on biochemical markers, particularly in Africa. We turn to the next slide now, please. And this is about within country inequalities. We have shown the differences between low income and middle income countries as a whole, but now we address the differences between wealth quintiles within countries. And we took the average of all these countries that we have with data. On the left, we show countries with wide inequality in women's anemia. Each circle is a quintile, ranging from the gold color circle, which is the lowest prevalence in the wealthier quintile, to the darker circle, which is the poorer quintile. And on the right, we show the growth faltering in the poorest and wealthiest quintiles in low and middle income countries. The dark colors are the poor and the golden colors are the wealthy. We show again huge gaps according to wealth within countries as well as between countries. So the next slide, please, is a data gaps. I have referred to this before. We now have much more data on anthropometry, but we have very little data less data on women than on children, and particularly less data on birth weight and gestational weight gain and micronutrient deficiencies in women. And regular data collection is essential for monitoring progress, implementing and targeting evaluations. Next, please. So what are the key messages from this paper? Number one, there's limited and uneven progress. So there are good news regarding stunting in children and low BMI in women, although that is also associated with increased overweight. There's a persisting burden of wasting, particularly in South Asia, high prevalence of micronutrient deficiencies, both in women and in children. I have mentioned the data gaps, but our findings reinforce the need for continued emphasis on the first 1,000 days, particularly regarding the KI consortium data on peak incidence of stunting wasting in the first 6 months. And the prevention of a low birth weight, wasting, and stunting depend on maternal nutrition, because in utero and during the first 6 months, the child who is exclusively breastfed will be completely dependent on his or her mother to provide adequate growth. And we also show that low BMI hotspots that require targeted action. Wrapping up, my next slide reinforces the fact that social inequalities are the major distal determinants of the global burden of childhood undernutrition. So we do need broad, multi-sectoral, anti-poverty initiatives as well as those initiatives that Rebecca and Zulfi will speak to you about with a more targeted nutrition-specific interventions addressed at the more proximate determinants of poor nutrition. Lastly, there's no question that COVID-19 will make things much worse before they get any better. Its impact on food availability and nutrition will require renewed action to prevent and to treat undernutrition in the near future. Thank you very much.
Thank you, Cesar, and that was really great. I'd like to invite our next speaker, Dr. Zulfiqar Bhutta, to present the next paper. Dr. Bhutta is the inaugural Robert Harding Chair in Global Child Health and Policy at the Hospital for Sick Children in Toronto, Canada, where he's also a Director of Research at the Sick Kids Center for Global Child Health. Dr. Bhutta was the founding director of the Center of Excellence in Women and Child Health and the Institute of Global Health and Development at Aga Khan University, which has programs and campuses in Pakistan, Afghanistan, East Africa, and the UK. Dr. Bhutta has many noteworthy professional achievements. Today, I simply mentioned that he was the lead author of the nutrition intervention papers in the 2008 and 2013 Lancet series, and he's the overall coordinator of the series we're launching today. Zulfi, please go ahead.
Thank you very much, Ellen, and I'm absolutely delighted, thrilled to be part of this ongoing work. So let's have the first slide, please. So what I would like to do on behalf of the large team of authors that worked on the update of the Lancet evidence is go through some of the thinking behind how we approached the evidence synthesis in 2021. So as you can imagine, the world has changed, and although our series is focusing on maternal and child undernutrition today, but there is increasing attention to the double and triple burden of malnutrition in many countries. And the countries that you see stippled here from our global nutrition report are the countries where you have a combination of overweight, obesity, anemia, and stunting in children. So our overall review paper also looks at interventions for overweight and obesity prevention, although today for this presentation, given the occasion of the International Women's Day, I'm going to largely focus on undernutrition in women and young infants. So our methods review was a bit different from our previous approach to doing this in the 2008 and 13 series. Firstly, we were focused a little more on the specific evidence that drew from low and middle income countries. We looked largely at direct nutrition interventions, but also included indirect nutrition interventions, and we spanned preconception to school age and adolescents in our review. We tried as much as possible to look at good quality reviews, particularly large-scale efficacy and effectiveness studies published post-1995 to take the most recent context into account. And where necessary, we looked at the changing context from what may have been different in the pre-1995 period. We published all of these prior to the Lancet series itself as a full supplement in nutrients. These 11 nutrition reviews are part of a special series which is available open access, and we also have corresponding Campbell library reviews. So this is the complete list of the background or the base intervention reviews that underpins this particular paper. And of these, I shall be focusing on a subset of highlighted interventions that pertain to mothers and young infants. So let's start with the mother first. So the good news is that we have a couple of interventions that I could categorize as reasonable interventions for women in pregnancy. So balanced energy protein remains a highly relevant intervention, particularly in populations, as Cesar described, where you have maternal underweight, wasting, and high prevalence of those problems. But as you can see, that we still have an overall paucity of evidence. Hardly close to around 1,900 subjects that have been evaluated over the years, and some of the largest studies are now several decades old. But you can see clearly that there is an impact, a significant impact on reducing low birth weight and small for gestational age, irrespective of the quality of the evidence per se. And this impact on small for gestational births remains quite evident, and the basis for our continued recommendation for ensuring that women have balanced energy protein available. The good news here is, as you will see in our review, that when you look at food supplementation programs, that you see a direction of effect and a size of impact, which is comparable to what these trials themselves show. Now, we looked at multiple micronutrients again. It's something that we've done consecutively for the last 2 series. And multiple micronutrient in pregnancies are important because a lot of the evidence, even though we may have data only for anemia at a global level, suggests that in many women of reproductive age, and indeed in pregnancy, most of the common deficiencies are multiple. And these multiple micronutrient deficiencies almost certainly require approaches that can specifically focus on the key micronutrients of interest. So these studies and reviews now number several dozens, and we looked at 33 randomized controlled trials. And we find clear evidence that they are, in terms of biological impact, superior to iron folic acid alone in terms of improving birth and child health outcomes. I wish I could say that we have the same evidence in terms of impact on maternal health, but other than anemia, we don't have that evidence from a large number of studies. They reduce stillbirths, they reduce low birth weights, births, and they importantly also have a reasonable impact on reducing small gestational age. And the impact is greater if you have formulations that have multiple micronutrients. So this busy forest plot tells you that overall we have a 7% reduction in small gestational age, but the impact is really significant where you have more than four or more micronutrients in the formulation, as opposed to those that have just a few. So this is an intervention that, in our opinion, is now ready for prime time. The only difference being that perhaps they're a bit more expensive than iron folic acid, but the economies of scale will take care of it. And we have made a strong recommendation in our review of now moving this to programs. We wanted to reevaluate micronutrient deficiencies in children, notably vitamin A and zinc deficiency, because that evidence has been around for a while and it's worth looking at this. So this particular paper in Nutrients looks at things a little differently from what we have done in the past. Firstly, we've excluded from this review, particularly children that represented special population, those with HIV, chronic diseases, low birth weight, etc. So focus on what might be an average population effect. And we looked at studies within LMICs. So what we find here is that although there is still a significant impact on height for age and height broadly in the same direction, the effect is lower than what it was in the prior periods. And this is also evident in terms of looking at the timing of some of those and changing context perhaps in the background. But we still believe that zinc is a very important preventive intervention in children, not just from the effect on linear growth, which may be lower than what we had estimated before, but because of its important impact on diarrhea. So preventive zinc supplementation reduces diarrhea incidence by 11%. And if you look at zinc for the treatment of diarrhea, it has a significant impact on reduction in diarrhea duration. And the modality for impacting undernutrition in many of these children affected by zinc deficiency is also through the diarrheal pathway, and that's the way it's modeled in the LifeSave tool. So zinc remains. But what about vitamin A, on which there has been a fair amount of noise in the general literature? Now, there is a changing context, and some countries with very robust programs of zinc supplementation, fortification, and growth, economic growth, have seen a change in their background pattern. And we see this reflected in the pre and post 1995 literature. So if you see the impact on mortality, which is one of the major reasons for providing vitamin A supplementation, the pre-1995 studies show a stronger impact and a more significant impact than what you see after 1995. But when you look at the totality of the evidence summarized here in this graphic, we still have a 12% reduction in child mortality with zinc supplementation given between 6 and 59 months of age. And this includes some of these larger evaluations in India, such as the Devta trial. So overall, our recommendation is to continue with zinc supplementation and vitamin A supplementation programs in countries where you have plausible evidence of population-based deficits. The real advance, and one that we have focused on in our particular review, is the newer development of small quantity lipid nutrient supplements. And I remember in 2013, this being shown as the first time as being very important interventions under development. And now 8 years on, we are sharing with you the overall evidence of their impact through a large number of studies. So small quantity lipid nutrient supplements given in populations where there's high prevalence of stunting does reduce severe stunting in young infants. And that impact is quite strong, 15% reduction in that extreme trend. But you see an impact on a large number of outcomes, and you see that summarized in this particular slide. So this systematic review that we undertook, and this has also been complemented by a recent individual subject data analysis. So there are several meta-analyses available on this, largely given to children between 6 and 23 months of age. And you can see that it impacts both moderate stunting, moderate wasting, and also reduces anemia by about a fifth. But in the IPD that was just published, children who received small quantity lipid nutrient supplements not only had a 12 to 14% reduction in stunting and about a 16% lowering in the prevalence of anemia, but importantly had close to 16 to 19% impact on developmental outcomes reflected in their scores for language, social, emotional, and motor development. Also important to underscore, although I think this requires further study, is the risk of mortality. And that seems to have reduced in the lipid nutrient supplement arms compared to comparison arms by close to around 27%. So that's a hugely important intervention in the right populations given for those who are at risk of these deficits. Sadly, although we did a pretty deep dive, and there is another set of reviews coming out in the Lancet, hopefully, which will look at the data for school-age children and adolescents. And on school-age children in particular, there is very little evidence from low and middle-income countries. There is some evidence from high-income countries. It largely derives from studies on prevention of obesity and overweight. And the same is true for adolescents. I thought we would find a lot more data on prevention of micronutrient deficiencies and other nutrition deficits in adolescents in low and middle-income countries, but that is not the case at the moment. We go through whatever evidence we have and summarize it in the paper, but this clearly underscores the need to do more, particularly in countries where you have the double burden and the nutrition transition in place. So how do I summarize the evidence? What about the Lancet 10 that we recommended in 2013? Well, the good news here, friends, is that those 10 remain, but they've been now supplemented by the small quantity lipid nutrient supplements. And I'm calling these the 11 samurai that we have in our global fight against maternal and child undernutrition. And these 11 interventions include now a little more targeting in terms of the micronutrient interventions to populations at risk, and also a stronger recommendation now to go to maternal multiple micronutrient supplementations and food basket or balanced energy protein supplements to women at risk. We still need more evidence, but overall in populations with low intakes of calcium, there are benefits to ensuring calcium intervention. And you will notice that for a number of these, including preventive zinc supplementation, which have not had large-scale programs, we have a vehicle, we have fortification strategies that we are recommending to prevent large-scale multiple micronutrient and mineral deficits in many of these populations that need to be scaled up. So we have a new conceptual framework. We are recommending that this be used for particularly programs and policymakers who look at the way they place nutrition interventions across the framework of not just health and nutrition programs, but also other sectors. So I've largely spoken to you about these direct sector nutrition interventions, but also would like to emphasize that there are indirect health sector and nutrition interventions that I've not spoken about. Things like family planning, maternal mental health, and disease prevention strategies. We also have the other sectors, the non-health, non-nutrition, intersectoral stuff that is extremely important, and that includes also things that will support fortification strategies and also those that underlie the importance of addressing social determinants of health, maternal education, changing age at first pregnancy, adolescent health, and sexual and reproductive health. There is also the continued recommendation, despite the fact that the trials may say something else, but as Rebecca may show you, of the importance of continuing the focus on water sanitation hygiene. And we have, of course, the delivery platforms, the cross-cutting issues around health system strengthening, community mobilization, and a focus on accountability. So let me close by saying that the key messages from our work, which is an update of what we did with 2008-13, are that we do have these evidence-based interventions. And they are a combination of indirect and direct interventions, both through health and non-health sectors. And they need to be implemented because they are important to get out there at scale. And currently, we do not believe that they are being implemented in entirety. You will hear more about this. We have new evidence of the importance of emerging interventions like small quantity of nutrient supplements, which need to be considered in population at risk. And I think the debate around using iron folic acid versus multiple micronutrients should now move very clearly to the scaling up of multiple micronutrients in pregnancy. We have evidence gaps that we need to fill, and hopefully someone, not me, may be presenting the next update in 5 or 6 years from now with stronger evidence around school age and adolescence, and newer evidence of the multi-sectorality of all of these being put together will be underscored in the next presentation. Thank you very much for your attention.
Thank you, Zulfi. That was an amazing synthesis, and thank you for doing it so succinctly. It's great to know that we have so much new evidence to work with, and yet we have a clear path with these 11 interventions. So now I'd finally like to welcome our third speaker, Dr. Rebecca Heidkamp, to present the next paper. Dr. Heidkamp is a faculty member in the Center for Human Nutrition in the Department of International Health at Johns Hopkins School of Public Health. She currently leads DataDent, an initiative focused on strengthening data value chains for nutrition, and she sits on the WHO UNICEF Technical Expert Advisory Group for Nutrition Monitoring, as well as on the board of the Society for Implementation Science for Nutrition. Prior to joining Johns Hopkins, Dr. Heidkamp spent a decade working in the NGO sector in Latin America, Africa, and the Caribbean. She holds a PhD in nutritional sciences from Cornell University. Rebecca, the floor is yours.
Thanks so much, Ellen. So I'm really honored to be presenting on behalf of my co-authors and countless others whose efforts underlie this paper, which aims to present a coherent action agenda towards achieving global undernutrition targets. Next slide, please. The 2020 Global Nutrition Report described global progress towards the targets as too slow, with anemia, stunting, and wasting off track, and some progress in low birth weight and breastfeeding. It's really important to stop and recognize that there are countries that are on course to specific targets, but far too many countries are making insufficient progress, and for several targets, we're somewhat in the dark due to insufficient data. Why is progress so slow so many years after the previous Lancet series refined our understanding of what works for undernutrition? Next slide. One explanation is that while we may know what works, we are still not actually delivering those interventions to the populations that need them. Coverage of direct nutrition interventions has been slow to change. Take, for example, iron folic acid during pregnancy. To the left in the purple box is coverage of antenatal care, the most common delivery platform for IFA. We see that across 17 low and middle income countries with data for at least 2 time points spanning the last decade, the proportion of women receiving at least 4 ANC visits remains stagnant at about 2/3. Immediately to the right, we see a small increase in the coverage of IFA over that same period. However, less than half of women who attended at least 4 ANC visits received at least 90 days of IFA. Closing this opportunity gap by ensuring that all women who attend ANC receive IFA is a clear priority. Echoing what we saw in paper 1, national level estimates mask serious inequities in intervention coverage. On the right, we see large disparities in IFA coverage across districts in India. The lightest shading have coverage less than 20%, while the darkest have higher than 80% coverage. Next slide. The slow progress in scaling up services begs the question why. In the paper, we assessed 20 direct nutrition interventions, most delivered by the health sector, across 6 criteria essential for interventions to reach scale. All but one of the interventions fully met the first criteria of evidence of effectiveness. However, they varied widely in terms of the other criteria for scaling. For example, breastfeeding counseling meets all criteria thanks to recent WHO guidance about breastfeeding counseling and new coverage questions in the DHS-8 core questionnaire. For calcium during pregnancy, we have a WHO recommendation and ANC as a delivery platform, but lack clarity on how to deliver the recommended dose, the costs, and the data to monitor. For treatment of moderate wasting, none of the criteria were fully met. Right now, there's no official WHO guidelines, there's a lack of specificity about products, and very little comparable data on coverage across countries. However, I will say that there's meaningful progress on all of these thanks to the efforts of several groups. Next slide. The Lancet 2013 series highlighted the potential of what it called nutrition-sensitive interventions to impact underlying determinants of malnutrition, but it concluded that the actual evidence base of nutritional impact was limited. The programmatic evidence base has advanced in meaningful ways since then. In the paper, we briefly summarized the 5 areas listed here. Just to give you an example, with large-scale food fortification, there's new evidence from country programs that confirms what we had previously seen in trials, that large-scale food fortification improves population-level micronutrient status. However, we are also clearer on the barriers to implementation, such as the challenge of establishing functional monitoring and quality assurance systems. Integration of nutrition goals into social protection programs is a growing priority, particularly as part of the COVID-19 response, but evidence of nutrition impacts remains mixed. And the findings from several large WASH trials since 2013 are pushing the sector to really contextualize their strategies, and in many places to pursue more advanced infrastructure. Next slide. One of the most exciting advances since 2013 is the new real-world evidence that supports multi-sector approaches to addressing undernutrition. Over the last 8 years, 2 research initiatives have carried out rigorous case studies in 11 countries and 4 Indian states that are positive outliers, meaning that stunting in children has no economic performance. These are rich studies, and I really encourage you to seek them out. But on high level, they show us that it is possible for low and middle income countries to make meaningful progress on stunting. The figure summarizes results from decomposition analyses to identify which factors explain stunting declines in each study. In many cases, indirect actions targeting underlying determinants like poverty, family planning, and parental education accounted for about half of the observed reduction in stunting. In other words, real-world evidence shows progress requires both direct and indirect actions across sectors. And the variability that's apparent in the figure confirms that there's no one-size-fits-all approach. However, there are a number of common elements that shape the enabling environments for this progress to be made. There is high-level commitment, cross-sector advocacy, investments in data, and attention to the coherence of policies and actions across sectors and administrative levels. Next slide. Next, in the wake of the 2013 Lancet series and the first Nutrition for Growth event, the Global Nutrition Report called for a nutrition data revolution over concerns that many countries do not have the necessary data to make problems visible, identify vulnerable populations, prioritize actions, track progress, and guide implementation. So what has actually happened with nutrition data and accountability? Well, for one, there's been a proliferation of global accountability efforts in a range of dashboards, scorecards, and tools looking at specific issues or regions. It's not clear how effective these are, but they have brought data front and center. Next slide. There's been full investments in strengthening other links of the nutrition data value chain. While nutrition still doesn't have a comprehensive indicator framework, we do have more and better data in the DHS questionnaire and in administrative data systems in many countries. Some countries are innovating with national health and nutrition surveys. COVID-19 has brought innovation to remote surveys. New analytical tools guide decisions around direct nutrition interventions and how to improve diet quality. But at country level, investments in nutrition data and information systems remain low. Data systems are not reflected in country strategic plans and budgets. And as you've heard previously, there are still critical information gaps around the magnitude of nutrition problems and the reach of multi-sector responses. Next slide. Another important milestone since 2013 is in the area of nutrition financing. In 2017, the new World Bank and partners released the first ever comprehensive estimate of the cost of reaching 4 of the WHO undernutrition targets. Next slide. The framework consisted of a specific set of direct nutrition interventions and estimated the overall cost to be an additional $70 billion over 10 years. One of the key assumptions was that indirect interventions would contribute half of the reduction through improvements in underlying determinants, but would be paid for by others. Next slide. In terms of where this additional 70 billion would come from, this figure illustrates the investment framework's assumptions that donor investment would increase for the first 6 years, but then taper off as domestic financing really ramped up. Actual financing data are limited. However, an analysis of the data from 2015 to 2017 shows that while donor spending on direct nutrition interventions increased, it was still short of projections. And most concerning was that there was evidence in several countries that domestic investment actually fell over the same period. Since 2013, we've seen the launch of innovation funding mechanisms like the Power of Nutrition, but particularly in light of COVID-19, we need to be even more innovative about how we do more with less. Next slide. The Nutrition for Growth Summit coming at the end of 2021 is an opportunity to demonstrate commitment to addressing the unfinished undernutrition agenda. Our paper lays out a detailed call to action, and the 5 high-level themes are summarized here. We need to accelerate financial commitments, particularly of domestic resources. And even today, in the face of COVID-19, we can make sure that our responses reflect nutrition goals. We need to increase coverage, improve quality, and address inequities for direct interventions in the first 1,000 days. Coverage is currently too variable and too inequitable to deliver impact. And we have interventions like multiple micronutrients during pregnancy and SQ-LNS that are only starting to be introduced. Implementation research is key. We need to identify and address the immediate and underlying determinants of undernutrition, and countries need to set their own national and subnational priorities around how to ensure that agriculture, social protection, education, and other sectors work towards impact on undernutrition. We have promising examples, but still need specific actions. We need to foster and sustain an enabling environment, and we need to invest in data and learning. New guidance on indicators and data systems are forthcoming, but countries need to put resources towards operationalizing these to their own benefit. The full call to action in our paper provides more specific recommendation under each of these. I would summarize the overall tone of this 2021 series as being both hard and hopeful. There's no denying that the progress is slow, and now COVID-19 poses a serious challenge in achieving many of the SDGs, including nutrition. However, there is cause for some optimism because we have examples of countries that are making progress. And even now, many countries have prioritized food and nutrition in their COVID-19 strategies. Thank you.
Thank you, Rebecca. I'd now like to invite Cesar and Zulfi to join us on camera for questions and discussion. And as we get started, I have a really quick question that I would like to pose to each of you to answer rapid fire. Can you tell me what you think the 1 or 2 new things that either excite you or surprise you most about this series are? And I'll start with you, Cesar.
Yeah, no, I think the most exciting news are the reinforcement of the importance of first 1,000 days, the new results from birth cohorts from the KI consortium showing that the peak incidence of stunting and wasting take place as early as the first 3 months of life. And the corollary of this reinforcement of the first 1,000 days is that maternal nutrition is essential, not only for women's own health, of course, but also for the health of their young children. A lot of what we see in terms of growth faltering takes place in utero or while the mother is still exclusively breastfeeding her infants. So we really must stop separating maternal from child nutrition or women's from child nutrition. And this is actually the most exciting finding from paper 1 in the series.
Thanks, Cesar. And Zulfi, what about for you? Anything surprise you or excite you particularly?
I would say excite me in particular, because just taking on from where Cesar left, I think the opportunity for doing a deeper dive on the benefits, particularly across the life course, for interventions earlier on, particularly with the mother, fetus, and newborn, young infant dyad, are limitless. And I think future intervention reviews should not only look at the outcomes that we've all been interested in the short term, like what happens to stunting, wasting, or survival, but really what happens across a life course. And increasingly intergenerational impacts will become a lot more important. So I think it's great to see that corroborated by the evidence per se. We haven't done the numbers yet, but we will be able to do so on the basis of what we've just published and provide estimates on how much impact this will make, at what cost, and what benefits might accrue over time. The one surprise and disappointment that I just mentioned is really how little is out there at this point in time to link the mother's own health and well-being outcomes to a lot of these interventions. And that's work that my group is particularly interested in undertaking now, because we have so far looked at maternal health outcomes largely from the lens of the fetus and the newborn. And I think it's time now to go beyond to look at her own health, mental health, long-term health outcomes, even things that may impact her later on in life. And those things are increasingly becoming important from just the pursuit of evidence-based interventions that impact the life course. So I would say that I thought there would be a lot more on that, not just from low-income countries, but from high-income countries, and there isn't, or people haven't looked at it that intently. So Ellen, that's work to be done, and needs to be done linking this early life interventions to longer-term outcomes.
Thank you, Zulfi. That's a particularly fitting observation today in International Women's Day. And how about you, Rebecca? What surprised you or excites you most in the series?
I think what excites me most is just that we really do have real world evidence that multi-sector strategies are needed, and that every sector has a contribution to make. You know, it's an idea that really came out in 2013, but we are seeing the reality of it. Now, there's a lot of room still to be done, a lot of work to do, but that's the most encouraging part to me.
Thank you. We have had an enormous number of questions coming in on the Q&A, and I have a few that I'll bring up for this discussion now. And I know that the co-authors have been busy answering all the questions, which we're really appreciative for. One set of questions really deals with the trends that we're seeing. So I suppose, Cesar, I'll give you the first crack at this question. It sounds like overall progress on stunting is being reported, but not so much in Asia. So can you comment on that? And another question is, why has there been no progress on wasting? Any insights on that particular finding? Over to you, Cesar.
Oh, thank you. Very good question. I think stunting and wasting are very different issues. Obviously, early wasting will lead to later stunting. But the epidemiology of wasting is still in many ways a big enigma, right? Why don't we have any wasting in Latin America? Why do we have 1% wasting in Guatemala where half the kids are stunted? Mm-hmm. And why do we have so much wasting in South Asia when at similar level of stunting, we have very little wasting in Africa, much less wasting in Africa. So it's really a big question. I think it is a mistake to consider that they have a common epidemiology. They have different risk factors. They have different timing, age patterns of occurrence. And there is issues like one of the issues that we have discussed in our paper is new evidence on the effect of the environment, of heavy contamination of the environment as a cause of undernutrition. Maybe the link will be there. We'll find differences in environmental contamination or what we used to call environmental enteropathy or environmental enteric dysfunction, that will explain part of these discrepancies. But it's really a puzzle. We don't really understand well why some parts of the world have much more wasting than they would be expected to have on the basis of their stunning prevalence. Thank you.
Thanks, Cesar. And there's a quick follow-up to this that I understand was not answered in the chat or the Q&A, which is that some people argue that exclusive breastfeeding in the first 6 months contributes to this high level of wasting and stunting in the early age groups. What are your thoughts on this? What can you say about the evidence related to that? And I think some others might want to jump in as well. So I'll let you start, Cesar, and then I think maybe Zulfi wants to answer as well.
Yeah, I can tell you that. And when we did the Lancet series on breastfeeding in 2016, we looked at every intervention trial. There is no, and then it's very complicated to relate breastfeeding to wasting or stunted in observational studies, because if the mother perceives that the baby is not growing well, she may continue breastfeeding or she may discontinue breastfeeding. So there's a loop of reversal causality there. But then we looked at trials, and what we found is, taken together, trials of promotion of exclusive breastfeeding had a very small effect on, positive effect on wasting, on weight for height, not a huge effect, a small effect. And we found no association with linear growth. So the association, and that is reviewed in our paper that just came out in this series, that the association between breastfeeding and stunting and wasting is not clear cut. But if anything, trials show that there is a positive effect on wasting. Having said that, the effects of breastfeeding on mortality are overwhelming. So you don't want to be concerned about the lack of effect on growth when you have such a huge effect on mortality. So this is the state of the art right now on breastfeeding growth and mortality. Thank you.
Thanks. Zulfi, you wanted to add?
Yeah, I'll go a step further than Cesar to say that there is absolutely no evidence from exclusive breastfeeding in the first 6 months of life of any adverse effect on growth. Most of the data that people have looked at to claim this are those where you have an issue with complementary feeding, where it's beyond 6 months of age, and continued breastfeeding alone with inappropriate complementary feeding has been noted. But as Cesar said, the benefits of breastfeeding to not just to nutrition, but to survival, and I would say to long-term outcomes, are so overwhelming. And in this day and age, as I said, you want double, triple duty nutrition interventions. And if there is one nutrition intervention that is a guarantee to impacting long-term optimal growth and prevention of obesity and overweight, that's breastfeeding. So I think breastfeeding needs to be supported 100%, and particularly exclusive breastfeeding early, with the interventions that are important to help mothers undertake this. So I find it difficult at times that we don't talk about interventions to support breastfeeding that also include interventions for women, like maternity leave, like appropriate economic support, policies to make it possible for women to breastfeed while still staying within the workforce. And those things are very important to underscore.
Thank you very much for that. I think I'll direct the next question over to Rebecca. And the question is that, has there been any work done, or what is the work that's been done since the last Lancet series to look at the barriers and enabling conditions that are necessary to get these known interventions implemented? In other words, we've known what to do for a long time. We're reinforcing the need for these things. But have we been good at looking at the barriers and the enablers, and what do we need to do next?
Yeah, so I think there is a kind of a general trend, but especially in the nutrition world, around implementation research and implementation science, this question of how do we deliver? I think one thing that's really important to remember is that that by nature needs to be contextualized. So it needs to be in many ways that at all levels, there's capacity to do that kind of systematic work at investigating why things aren't scaling and addressing the barriers that are there. But there have been a few examples of, I think, multi-country implementation research initiatives. I know that alongside, for example, groups that are promoting the switch to MMS. They're having an implementation research come alongside introduction and scale up. So I do think there's a shift, but the reality is that we need people kind of with that hat at all levels. It's not going to be a top down from the outside approach to improving what needs to be done in a particular context.
Thank you for that. I know that's a subject that the commentary addressed as well for this series. Another question or set of questions have come in around how to actually prioritize greater investment, particularly given the austere financial situation that we're in today. And I think I'd like all of the authors to comment on this one. What can we really do to motivate investment in this area? I'll let you start, Rebecca, and then I'll go to Cesar and Zulfi.
Well, you know, with every tragedy, there's opportunity, right? And I think right now we're facing this global tragedy of COVID-19, but we know that this really can be a focusing event. And so if we're mindful about, you know, there's been a lot of work that a number of people have been involved with around showing how disruptions to economic and food systems have direct impact on undernutrition. So even while undernutrition and COVID are not linked the same way we're hearing about NCDs and COVID, there's a real case for why in this moment, we should take it as an event and really highlight the ties to the undernutrition and the nutrition target agenda in all countries.
Thanks. Cesar, do you want to add next?
I have very little to add to what Rebecca said, other than a sort of a real life observation. You know, after 20 years of seeing no kids begging on the streets of Pelotas where I live, they are back. They are back now. Mm-hmm. They are out of school. They've been out of school for 1 year now. Mm-hmm. And there is a lot of begging for food, which is just to give us, you know, Brazil is a middle income country, which reduced the prevalence of stunting from 30% to about 7% in 20 years. And I'm really afraid of what's happening next. But that is an extra incentive for focusing even more on nutrition relevant interventions, because the situation now is definitely much more dramatic than it was only 1 year ago when the pandemic first spread out.
Thank you. And Zulfi?
So Ellen, I hope as part of this series update that we will have an opportunity to advocate and present the evidence to a group of people that we typically don't speak to. And those are the ministers of finance and ministers of social protection and welfare, for a variety of reasons. One is, as Cesar and Rebecca have said, the crisis that's upon us. And we really need some short-term fixes to ensure that we don't slide back and reverse the progress of the last several decades in terms of addressing maternal and child undernutrition. And for every child that you see undernourished and begging on the streets, whether it's the streets of Pelotas or elsewhere, there is a family and there is a mother behind it. The second is that nutrition interventions for countries and investments are exactly that. They are an investment, they're not an expense. And they are an investment in terms of return for investment that are the best buys possible for any given society or economy. There is not a single country in the world that has climbed up the development ladder with a malnourished population. And big countries, especially with birth cohorts in several millions, just cannot afford to have a quarter to a third of their birth cohort being born low birth weight, stunted, and with adverse educational long-term development outcomes. So I'd like to present our evidence on the data, as well as on the interventions and solutions possible as an investment. And this is what countries need to make, just as they would make investments in infrastructure, in building roads, in ensuring that their living conditions are better. Without improving the nutrition of the mother and baby and lifting the entire ship up, I don't think you can ever make that progress. So I hope that people will look at both the short-term exigencies and the needs that we have for action, with both solidifying and consolidating this in a sustainable manner. So this is looked as a development priority.
Thank you. That was really great answers to those questions from all three of you. A number of questions have come in on the Q&A related to local foods and the potential for improving local foods and diets as a solution to undernutrition. And so I was wondering if you could all give a crack at that question. What role do local foods have? And I know the food system has been getting a lot of attention. There's a UN food summit coming up, food system summit coming up this fall. What do you all think about the role of improving the local food system and local foods to address undernutrition? And I'll start with you, Zulfi, and then go backwards, Cesar and Rebecca, you'll have the last word.
So great question, because it always comes up. Why processed foods and why not locally available foods? So the answer to that is, if you have a diverse food basket, and if families can afford to purchase those foods, absolutely, we would always favor that. And there is some evidence emerging that where there were subsistence farming of a diverse nature in Africa and other parts of the world, the impact of COVID-19 in terms of nutrition has been much less than it has been in other places. So I think absolutely, if food is available, that's the solution. And especially if people can afford it, that's the solution. The problem that we have, Alan, as you know, is that in many parts of the world, and increasingly in our urban slums where people don't have what I just mentioned, subsistence farming and access to fresh foods and products, that is not the case. And people neither have the access to a diverse food basket, nor the means to purchase those commodities at the market prices that are available. And those are generally very sensitive to price fluctuations. And there you need to have solutions that are not left to happenstance, that you need to have things that are available in the form of commodities. I think one of the advantages of small quantity lipid nutrient supplements is really in food insecure households. Our recommendation for providing food supplements is also in food insecure households where you do not have that mechanism, thereby by state providing some of that. It's very important. My final point on that is that we also know that for particularly mothers, if they have access to appropriate foods, the impact of food basket support is the same as providing balanced energy protein supplements as a research product. So I would make the case that countries should strive to, where they have the ability and the access to those foods, to make those foods available at affordable prices or the cash support for people to purchase it. But where they are not available, you don't leave them at the mercy of the market. And the market may not be affordable despite whatever you may give as cash support.
Thanks, Zulfi. And we have about a minute left for the Q&A. So Cesar and Rebecca, any last comments on this or anything else you'd like to say before we close out the panel? Cesar?
No, the only thing I wanted to say is that it is a real fortunate opportunity that this event is taking place on International Women's Day. We're really very much aware of the relationships between maternal nutrition and child nutrition. We know that women's nutrition go well beyond the role that maternal nutrition has for their children's growth, but we know much more now about the importance of the maternal nutrition interventions to support ideal, optimal child growth in the first 1,000 days. So thank you very much. It's been a great opportunity to be here. Over to Rebecca.
Yeah, I echo that. And maybe just coming back to the local food question, I think this is where the importance of policy coherence, when we talk about these success stories where there's enabling environments, and one of those enabling environments is coherence of policies across sectors. So especially as we see more of a push to introduce and scale nutrition through social protection, through some of these areas, that question then how local foods become part of it is a conversation and an act of political will that has to happen across the sectors. So.
Thank you. And I'd just like to thank everyone on the panel and the audience for these great questions in this discussion. And I know someone wants to say more, but we are at time. So before we turn to the next panel, I invite you to watch this short video.
Nutrition. It is central to life. It fuels bodies and minds from before birth through old age, driving physical growth and cognitive development for individuals and delivering health and economic benefits for all. Yet too often, nutrition's importance is overlooked. Hunger and malnutrition remain hidden. For decades, malnutrition has been the underlying cause of nearly half of all child deaths. Poor diets are now the #1 cause of preventable deaths on the planet. And that was before the pandemic. COVID-19 has changed our way of life. We have all felt its effects, but we haven't felt them equally. For the world's poorest and most marginalized, especially women and children, malnutrition may be the pandemic's worst and longest lasting impact. But malnutrition doesn't just threaten individuals' health. It threatens to undo decades of progress on all our global goals. Unless we choose a better path forward, unless we create a future unbound by the challenges of malnutrition. With action, we can make 2021 not a year where progress is undone, but where it is accelerated. A future where nutrition is visible and understood and prioritized for all, where health, food, and social protection systems are designed to help people live healthy and productive lives, where gender equality is prioritized and women and girls have the agency, opportunity, and energy to lead, where nutrition is the first line of defense against infectious diseases and chronic illness, and where the intergenerational cycle of malnutrition stops once and for all. With less than 10 years to achieve the Sustainable Development Goals, each one of us has a role to play as experts, practitioners, parents, advocates, human beings. Together, we can make 2021 a year of accelerated progress towards the goals by unlocking the power of good nutrition for all. Welcome to the Nutrition for Growth Year of Action.
Well, as you heard in the video, together we can make 2021 a year when nutrition is visible, understood, and prioritized for all. Achieving our nutrition goals requires work across many sectors and systems, including health, food, and social protection, to name just a few. We're going to touch on these issues in the second portion of the agenda, and now I'd like to welcome 3 outstanding panelists and nutrition champions to join me on camera. Allow me to introduce each of you first before we jump into the discussion. And listeners, once again, you can pose questions in the Q&A feature. First, Dr. Sonia Nishtar, and I'm proud to say Senator-elect Nishtar, congratulations on your recent election victory. Dr. Nishtar is a physician, cardiologist, author, and activist who currently serves as the Special Assistant on Poverty Alleviation and Social Safety to the Prime Minister of Pakistan. In this capacity, she's responsible, among many things, for overseeing EHSAS, Pakistan's multi-sectoral social protection program to improve the lives and livelihoods of millions of marginalized families in Pakistan. Dr. Nishtar has chaired and co-chaired many global health and nutrition commissions. She graduated from the Khyber Medical University and is a fellow of the Royal College of Physicians of London. She also holds a PhD and a Doctor of Science from King's College in London. Dr. Ruth Onyango, hailing from Kenya, is a professor of food science and nutrition and herself a former member of parliament. She created Rural Outreach Africa to empower smallholder farmers to address malnutrition by supporting them in food production and agricultural processing. She's the founder and editor-in-chief of the African Journal of Food, Agriculture, Nutrition, and Development. She serves on a number of boards and has won several awards nationally and internationally, including being the 2017 winner of the Africa Food Prize. And our third panelist, Dr. Meera Shekhar, originally from India, is the global lead for nutrition at the World Bank Group. And she's currently the chair of the Scaling Up Nutrition, or SUN, Executive Committee. She's published extensively on nutrition as an investment in human capital and development, and she actually led the development of the first ever global investment framework for nutrition. She's also led the development of the Optima Nutrition Tool, which aims to maximize the impact of nutrition spending. Dr. Zulfiqar has a PhD in international nutrition, epidemiology, and population studies from Cornell University. So welcome to each of you. I'd like to start off this panel discussion with a question in celebration of International Women's Day. And I was wondering if each of you could share with us something about a woman who's inspired you in your careers. And it could be anyone, famous or not, who's really influenced you. So I'll start with you, Mira, and then over to you, Sonia and Ruth. Mira?
Okay, great. Thank you, Ellen, for that question. So besides yourself, I think if I had to name women per se that have inspired me, I would like to name the millions of frontline community health workers, community extension workers who deliver the services that all of us depend on so much for scaling up the nutrition agenda. So whether it is the millions of community health workers in all of Africa, or the lady health visitors in Pakistan, or the more than 1.5 million Anganwadi workers in India, what they do. And think about there was a story about this woman in Bangladesh who delivered nutrition services in a flood. She swam through the floods to deliver these services. So not only am I inspired by these women, but I'm in constant awe of what they do.
Wow, thank you. Sonia.
Well, thank you so much for having me on the panel, and good day to everyone around the screen. In terms of the inspiration, I work with many disadvantaged women. I'm responsible for the execution of SAS, which is a social protection program. We reach out to millions of women with cash stipends, with conditional cash transfers, with cash for work, with a whole host of other benefits. And during the course of my work, I come across millions of amazing stories, millions of women, and their resilience, their hard work, and their dedication continues to inspire me. Just 2 weeks ago, I met this woman in a very disadvantaged remote rural setting. She had been identified through our National Socioeconomic Survey for support. And when I met her, she narrated her story to me. She was a masseur in the local village. She was very elderly. She had a sick husband at home who had suffered from a stroke. She had 3 disabled children. And she was very osteoporotic and had very bad eyesight because she's quite advanced in her age. And she had a tendency to fall again and again. She had broken both her right and her left wrist. Imagine the only earning member in a family of 5, an elderly woman who earns her living by working as a masseur in a village, breaks both her wrists. Both her wrists were in a cast, but despite that, she was very upbeat, and she was telling me that she will soon be out. Her arms are going to be soon out of these casts. She will no longer entirely subsist on the assistance the government gives, and she will be back to work. And it brought tears to my eyes listening to her story, and her resilience, her attitude towards her life, her courage was so very inspiring. I can continue to narrate millions of stories like that.
Wow, thank you. And Ruth, how about you? Who's inspired you in your life?
Thank you, Ellen. I'm not different from my colleagues, but I'll say this: my mother for sure. I remember her waking up at 5 a.m. in the morning, making a full meal for me to have before I could go to school, and just learning about what she and her colleagues went through to make sure that they fed their children. I didn't see too much malnutrition at that time. We had other diseases that actually killed babies, and like malaria, and it still does. And my mother was my biggest inspiration. But mid-career, I went to the ground, I went to the ground to just see where food in Africa was coming from. And truly, I proved it was mostly women, toiling away on the farms, and it's not just in Kenya. And as I've traveled now across Africa, also in Asia, you just find women toiling away. They'll do anything to try and just get food to feed their families. And it's just given me a voice. I've become an advocate for this. And it just keeps making you want to do a lot more because, you are living in luxury and see what they go through to virtually feed the world. Yeah. So that has been my inspiration throughout my career. Thank you, Ellen.
Wow. So all three of you women are indeed incredibly inspiring, but I think it's remarkable that you all actually turned the question around and acknowledged the work, the hard work, dedication, and amazing feats of women all around the world. So my next question then, in the previous hour, we learned a great deal about the burden of maternal and child undernutrition, its consequences, and what can be done to alleviate it. But we also learned that progress has been slow. So from your perspective today, what do you think is the most critical thing that has to happen to translate evidence about what we know works to address this problem into practice? And I'm going to start with you, Dr. Nishtar Sanya. As special advisor to the Prime Minister, you're responsible for one of the world's largest multi-sectoral poverty alleviation and social protection initiatives. As the Nutrition for Growth Year of Action kicked off in December, the government of Pakistan committed to spending upwards of $2 billion by 2025 to address malnutrition and stunting. So from your perspective, what are the most urgent priorities for these initiatives to accelerate progress in Pakistan? Over to you, Sanya.
Well, first of all, in terms of your question, you answered your question by stating up front that progress has been slow. So in terms of what needs to happen, there has to be a focus on implementation. And I couldn't stress more on that. There's a wide body of evidence. We know what works, we know what to accelerate, we know what to cascade into implementation. And I think the governments and their partners, their implementing partners all over the world really have to focus on implementation. Now, as far as nutrition is concerned, because it is multi-sectoral, it's multi-component, there are a whole host of stakeholders. Because it is everybody's business, nobody thinks they're fully responsible. This is really a challenge for implementation. In our own country, you referred to the commitment by the government of Pakistan, you referred to the explicit figure that was committed. And your question was, how is that commitment cascading into implementation? So I think the first step is to recognize the burden of the problem. And I know that Zulfiqar is on the screen with us. He has been at the forefront of knowledge sharing, of evidence gathering. And he's the best person to let you know that our trend lines, our nutrition-related trend lines, particularly for stunting, wasting, undernutrition, have been virtually horizontal. Trend lines have been horizontal over the last 60, 65 years since we've started gathering information. Of these trend lines, the trends of stunting are the most glaring, are the most worrying, particularly in this day and age where human capital is considered to be the wealth of a nation. In this digital age, there is an explicit recognition that unless countries will invest in human capital, they are not going to be able to compete in the world of tomorrow. Human capital constitutes 60% of the wealth of a nation, and some of the multilateral institutions have gone as far as saying that the borrowing costs of countries are going to be linked to their human capital rankings. So the recognition of the gravity of the situation is a starting point, And as you know, our Prime Minister, in his opening speech, held up the CT scan of a child with a stunted, with a stunted brain, and committed that he will have a program to address stunting. So it was very natural for us when we conceptualized SRs to have one of its 4 pillars dedicated on human capital development, a program aimed at addressing malnutrition more generally and stunting more specifically is a government-wide program, which is currently it's being cascaded into implementation because it is multi-component. There are different responsibilities of various ministries, as you yourself said right at the very beginning. Nutrition cross-cuts health, food, agriculture, food systems, social protection, the work of local governments, water sanitation. There's a whole long list of stakeholders and institutions at various levels of government. So the government's nutrition plan is, there are various responsibilities with reference to execution. There is a National Nutrition Council which the Prime Minister chairs, and the Nutrition Council is supposed to meet every 6 months to take stock of implementation. As far as social protection is concerned, there are some threads related to nutrition that are my direct responsibility. And within that context, we rolled out a health and nutrition conditional cash transfer program, the first ever in the country. About a year ago, there was a year-long consultative process and design process that informed its design. We are embedding evaluation into the design of the program. It's basically cash transfers which are conditional to certain health-seeking behaviors, to immunization, to antenatal care, and to the consumption of specialized nutrition food, both as a preventive measure in deeply impoverished populations, as well as consumption of therapeutic nutritional food wherever the need arises. This conditional cash transfer program centered on health and nutrition outcomes has currently been deployed in 23 of the most disadvantaged districts of the country, and based on the initial process-related results, we plan to upscale the program. So that's one of the things that falls on my plate. And of course, the many provincial governments are upscaling this program according to their own formats. And we're seeking collaboration with several provincial governments who would like to replicate the SRS model as such. The Prime Minister was also very keen to have a soup kitchen initiative, and especially during COVID, this one-of-the-kind program, Soup Kitchen Initiative, received a lot of attention because there was huge need. The model of this Soup Kitchen Initiative is centered on a public-private partnership design. So basically, it costs the government zero because there is this huge culture of philanthropy and giving. And giving away of food is something that individuals do at a massive scale, and there are NGOs and organizations in the country who have huge expertise in mobilizing hundreds and thousands of meals, distributing them to needy populations. So we forged quite an innovative public-private partnership using government's assets and promoting the use of government land for soup kitchens where NGOs operate. Other than this, as you know, we are currently at the cusp of completing our new National Socioeconomic Survey. A new registry will be available after a 10-year delay. Based on the results of that new registry, we have already started expanding our social protection payments to over 7 million families in the country. Just today, the Prime Minister approved the design of a commodity subsidies program, which we will be launching in collaboration with the Central Bank of the country. The plan is to give commodity subsidies to about 27 million households in Pakistan, which will make SARS the largest social protection program, arguably in the world. And the approval for this was given by the Prime Minister in a meeting actually this afternoon. There are many other policy strands within SARS focused on the empowerment of women who work in the agriculture sector, recognizing their work, and we feel that this is going to have a positive impact on nutrition outcomes as well. We have bolstered the scale and the scope of our conditional cash transfer program on the education-related conditional cash transfer program. When I took over, it was operating in 50 districts. It is now operating in all 154 districts of the country. And I'm very pleased to let you know that under a fundamental policy shift, we decided that all the conditional cash transfer programs of the government of Pakistan, whether they are health and nutrition related or whether they are education conditionality related, will have a higher stipend amount for girls. So the stipend for girls is much higher because we see this decision was also taken in the context of the post-COVID threats to girls' nutrition, because whenever the income of a household is squeezed, the likelihood of a girl being pulled out of school is much higher. The likelihood of a girl being fed less is far more. The likelihood of a woman going hungry is far greater. So these pro-women measures were taken in the light of, particularly the light of the threats that emanate from the COVID context. We say that SARS is 50% plus for women. At least 50% of the benefits across all the benefits are centered on women. I can continue to expand on that subsequently, but over back to you.
Thank you so much. And you really did point out the multi-sectoral nature of what's needed to really make change in undernutrition. And I just want to call out that you mentioned the embedding of evaluation into the work. So I look forward in another couple of years to hearing about those lessons and what actions were taken as a result of them. But over to you, Ruth. I know you as a professor, committed teacher, and the founder and editor of Africa's premier scholarly journal on food, agriculture, nutrition, and development. From your perspective as someone who has worked at the nexus between nutrition, agriculture, and food systems in Africa, what do you think are the few most critical steps to address maternal and child undernutrition in the region where you work? Ruth, a few remarks, please.
Thank you. From what I've seen over the years, I think what has been so excellently presented by the authors, Cesar, and Bhutta and Rebecca, it just was so amazing what I listened to them. It's just been building up, and yet we continue to have issues of, in Africa particularly, data gaps. If you don't know what people are doing, what is going on, what mothers are eating, what the deficiencies are, you cannot really recommend implementation properly. So that's an area. I remember the World Bank, when I started my work, used to assist us, especially here in Kenya. They would actually train statisticians. We do budget surveys, and then we do food consumption surveys, and our economies cannot afford those kinds of studies, but one could still do it at a very local level, because implementation has to be done at a very local level. The other thing that I saw come out, and I need to point this out, is where you have mother and child going together. I think all of them emphasize this, and it's something I've always thought, why do we separate mother and child? And they are so interdependent, and it's a win-win situation when you consider them together, whatever you give. And if it is social safety nets, whether it's government giving supplements, it has to be done at the local level. But then we need to invest in training. We stopped training nutritionists in a big way. We have food scientists also who are not even taken seriously. But I can tell you, Ellen, that I've seen during this COVID that there's now a more focus more focus on not just food, but the quality of food. Why? It's come out very clearly that the immunity is affected, by this corona. And so the quality of food, diverse foods, our own cultural foods, which are healthy, we all want to go back to them, but it has to be taken up as a big policy issue. We need a capacity building, we need retraining. We need people, in the community, those community health workers doing their work and knowing what they're doing and advising mothers right at the local level. We don't have the data yet, but I believe breastfeeding must have been up. But then we need to continue preaching and emphasizing why, breastfeeding is absolutely critical. It's the foundation that builds you throughout life, but also, like Bhutta says, also determines, how you fare at the end of your life. So that's important for me. And then what Rebecca came up with, implementation science. We know what to do. To a large extent, we know what to do. But how to implement? So we continue to have all these nice programs. Donors come in, we are giving you food, and we are doing this and diverse. But at the same time, the numbers that just don't match what we are preaching. So there's a lot to do. I believe that political will is absolutely necessary. We are all in this. Then we need to go and implement at the ground level. We need to train, at the universities, and we need to simplify all this information that we have. And then the issue of investment, we should see it as an investment. We cannot build an economy with malnourished people. And malnourished people cannot enjoy life. And the video you showed, I'm happy for the first time, you showed happy children, happy, healthy children of whatever race. They look good. And happy mothers, and happy fathers. Yeah. So we really need now to rethink. And I think this year is an opportunity for us to come up with the new strategies and new ways of doing things. Yeah.
Thank you, Ruth. That's a perfect segue to my question for Mira. So you're known for many things, but one thing that stands out from your work at the World Bank is advocating for more money for nutrition and delivering more nutrition for the money. So I know in terms of more money for nutrition, the World Bank has increased its nutrition project pipeline by more than 100-fold since 2010 to over up to $1 billion in fiscal years 2018 and 2019, respectively. That's really impressive. But I want to ask you about the other side of the equation. Based on what you heard today and your experience, what do we need to do to deliver more nutrition for the money?
Great question, Ellen, as always. Yes, indeed, from the bank side, we have scaled up. And I think one of the reasons we have been able to scale up is because we've focused on really not just the what needs to be scaled up, but the how. And you'll read quite a bit of that in the commentary as well that we wrote. We've tried not to scale up, focus on scaling up what works, but slight nuance. We've tried to build models that are scalable. And that's a lesson learned from the private sector, that we can develop models that are scalable. How do we do that? We use existing platforms, such as social protection platforms that Sanya referred to deliver nutrition services. We use, certainly we need to do a lot more of that. I'm not saying we've done it all, but these are sorts of things. Primary healthcare platforms that Rebecca referred to as the opportunity gap in her paper. Scaling those, using those to scale up nutrition interventions. I think we've really aspired to do some of that. But on the other hand, one lesson we've learned from all the countries that we work with is that we ask them to scale up these programs, but they don't necessarily have the resources. So working with them to help leverage resources is absolutely critical. And in these COVID times, we know ODA resources are limited, overseas development aid is limited, domestic resources are being crunched as well at the moment. And so I think we will really need to focus much more on innovative financing as we go forward to scale up all the what's that the Lancet series have laid out. Because without that, we will not be able to achieve. And then how do we get more nutrition out of the money? Well, as I said, using existing platforms, and then also ensuring that we improve the efficiency of the spending. Money is limited, resources are limited. If we can get more out of it by using tools such as Optima Nutrition that you referred to earlier, that really builds on the list tool, but it helps countries identify which interventions they might want to prioritize, which sub-geographies within their own country contexts that they might want to prioritize for scaling up, which population groups they might want to scale up with. Maximizing those will really help to get the most impact that we're looking for. There's no single recipe, but using some of these tools and approaches that the health sector has used, like results-based financing and performance-based financing for our health workers, these are the sorts of tools that really can get us to where we need to go. Thanks.
Thank you, Mira. I know there have been several questions in the Q&A, but unfortunately, I don't think we're going to have time to get to them. We will have them answered for you all later. I have one final question for the panel, and we just have about 5 minutes left. So really quickly, 2021, as we've heard, has been named the Nutrition Year of Action. What do each of you hope or expect this community to do to positively influence the lives of girls, women, and families right now, today, and in the future? So what does success in 2021 look like for you? And I'll start with you, Ruth, very quickly. What does it look like for you, perhaps from your civil society, as you just gave us, and the African perspective? What do you hope to see happen in 2021? Ruth?
Yeah, thank you, Ellen. And again, let me say thank you so much for having me here. I just say that I see advocacy and I see awareness created on the need to have a healthy nation. And it all starts with that baby in the womb. And an unhealthy girl and an unhealthy mother cannot give birth to a healthy child. And I see this year as we go to the summit later in the year, that we can bring something to the table where we can mobilize more investments and see this as an investment, seriously. See this as an investment. You know, I think it's Bhutta who said that, you know, it has to be an investment. And that's the message we have been trying to give, but I think right now it's sounding even more serious, more convincing, and much more better. And I hope this information, when presented, will actually make that case. And people like Mira, who are at the World Bank, who influence our governments, need to actually make sure that our donors and our governments actually implement this, and it can be something we can work on very seriously. Yeah.
Thank you, Ruth. And Sanya, we heard a lot about your about Pakistan. I know you sit on a lot of global panels and committees, and part of the Sun Lead group as well. So perhaps can you just speak about what you see the top priority is from either, you know, from the global perspective, or as well as your own country? Over to you.
So I think in terms of global priorities, I think I have to agree with Ruth that human capital development and investments in nutrition have to be seen as part of an investment, not a nice thing to do, not a tick the box, not a line item that has to that you have to pay lip service to. We are moving into a very different age compared to what we lived in the past, and in this future, human capital really matters, and we know that nutrition in early life has an important bearing on human capital development. So governments will have to view this reality in very concrete terms and view it as a true investment, number one. Secondly, action has to be very concrete, and within that context, we need good data, we need evidence about what works, in very granular implementation terms, not in generic terms. I think the international institutions can play a very important role in setting up demonstration areas, in sharing of experience, in ways that will help implementation and in ways that will help move the needle. So that's the second important things from the global perspective. And thirdly, accountability for action. It's not fair for the international community and multilateral institutions and governments to be coming to these international fora and to be making commitments, and for them not to be held accountable for failing to deliver on them. I say that as a government person. I think it is so very important that we do not pay lip service and cascade these important goals into speeches that are meant only for important rostra, but that we actually hold ourselves accountable to what we promise. And I think that the combination of these three important things and the role of the international community to bring to bear the importance of concrete action and accountability for delivery on promises is where the Food Summit can play a very important role.
Thank you so much. And thank you for bringing up the all-important accountability comment. And so Mira, you get the final word here. Quickly, what does success look like for you in 2021?
Okay, great. First, I want to reiterate all the things that Sanya and Ruth said. I completely agree with all of those comments, including the accountability piece. Really important. So from my perspective, I think of three things for 2021. First, of course, we've got to beat the pandemic. It's absolutely critical. We beat the pandemic and then get the world back on a trajectory of stronger economic growth, better nutrition, livelihoods, jobs, all the things that are absolutely critical. And we know we'll never go back to normal per se, but the new normal needs to be more resilient, and nutrition needs to play a very important part in it. So that's one. The second thing would be, my motto is always never let a crisis go to waste. We do have a crisis on our hands, but we also have new evidence that shows us the links between obesity and COVID. And there are many governments that are now willing to do something about it, where they may have been less willing in the past. So that's a chance to do something more on that level. And lastly, I always end with financing. We have to, in 2021, make sure that we help countries access the resources that are necessary to scale up. As I said earlier, overseas aid is going to be limited. We still need to keep pushing on that door. Domestic financing is going to be limited, but we do need, perhaps this is the opportunity to push the private sector to join on the financing bandwagon, help scale up innovative financing opportunities such as the power of nutrition, and make sure countries get the resources that they need to scale up. Thank you.
Thank you, Mira, and thank you to all three of you for joining today and for sharing your thoughts. That was really an excellent discussion. Thank you so much. We have one more guest I'd like to welcome to say a few closing words. Joining us next is Sean Baker, the Chief Nutritionist for the U.S. Agency for International Development. In this position, Sean chairs the agency's Nutrition Leadership Council. He oversees the vision and strategy of the agency's Center for Nutrition in the Bureau for Resilience and Food Security, and he coordinates related efforts all across USAID. Sean has more than 40 years of experience in public health, nutrition, and food security, and I'm proud to say that I've known Sean for at least 25 of those 40 years, and he has a remarkable way of inspiring us to translate all this evidence into action. So Sean, please go ahead.
Thank you, Ellen, for that generous introduction, and probably to be transparent, almost anything I know about nutrition has some roots in Ellen's influence. So she's been one of, if I think of nutrition heroes, Ellen is certainly top of the list. And talking about nutrition heroes and people to whom I think all of us who work in nutrition owe an incredible debt of gratitude, it is really all the authors who've contributed to these series going back to 2008. I think all of us have a debt of gratitude, and the women and children we serve have a debt of gratitude. As I've often said, every revolution needs a good narrative, and the Lancet series starting back in 2008 have been this evidence-based narrative of the revolution that started when this was published. I think I'm paraphrasing Rebecca as I read through this set of manuscripts and the commentary. It was both very sobering, but also very energizing. And when I spoke to colleagues, I tried to summarize it in 4 R's. I think it really reaffirms what we know works in nutrition and the people we need to focus on. It reinforces, in fact, areas we've neglected and we really need to double down efforts on. I think it's revealed gaps in knowledge, but it's also revealed some new solutions that are exciting and an evidence that when we come together, things can work. And it really has provided a rallying call for a path forward. If I take USAID as an example, these series starting back in 2008 have deeply shaped the way we approach nutrition. The inaugural series in 2008 came out at a time just when the US government was starting its Feed the Future initiative. And if nutrition is one of the pillars of Feed the Future, and a focus on making sure that we're paying attention to women's diets, it is really because of this series, as well as the focus in Feed the Future on the 1,000-day window, both in our specific and sensitive programming. The 2013 series really was instrumental in shaping USAID's multi-sectoral nutrition strategy and has informed both what we have done in terms of delivering of nutrition-specific interventions. And also, I think it's very reassuring to see the evidence in this series of when you actually bring sectors together in the right way, you can see improvements in reducing all forms of malnutrition. And that plays out also in our own experience of in Feed the Future zones of influence. There's been a reduction in the number of children who are stunted by about 3.4 million. Again, reiterating that when you bring it together, it can work. It's deeply informed the way we are we are prioritizing nutrition-specific interventions through the health sector. And in 2019, through our health sector program, we reached about over 27 million kids and over 8.5 million pregnant women with high impact interventions that are aligned with the evidence base here. And through partnership with UNICEF the last 2 years, we've enabled treatment of about 2.3 million children. We've also, I think, taken heart from the lessons of governance, as Ellen has referred to, of setting up our internal Nutrition Leadership Council, which helps bring together all parts of USAID, both to better coordinate, but also to better elevate. And we're seeing this play out across the broader US government with the refresh of the Global Food Security Strategy and the development of the second Global Nutrition Coordination Plan. So I think all of these are examples, living proof that if we are intentional, we can drive progress. But, and this is where I think it was a bit more grim reading, it's clear also we have a lot of work to do as a community. And I think I'm quoting correctly in one of the summary conclusions is that we have no time to waste to get together and accelerate. One of the things that keeps me most awake at night most is the fragility of our progress and the inequity of our progress. I think we have all lived through COVID-19 and seen the devastating impacts about everything that's happened. The next pandemic could be other progress, and for the ongoing climate crisis is also going to make it harder and increase those underlying inequities. It's also, I think this series has been very important in calling out some of the specific gaps where we need to accelerate action as a top priority, including the unfinished agenda on micronutrient malnutrition and how do we really reposition large-scale food fortification as a non-negotiable for the food systems. We've seen how much we've actually faltered on women's nutrition and all the consequences. I think it's exciting to have the call out of these missed opportunities in the health sector, and that may be one of the biggest areas we can ramp up impact most quickly. And as we go into this make or break year, we are certainly deeply engaged in all these events, the UN Food System Summit and the Nutrition for Growth Year of Action, so we can really re-elevate and re-energize. And this series, I think, comes at the most opportune time because it's really, again, continuing to provide that evidence-based narrative of what needs to happen and a call to action. I recently had an interview and I was making the case of why this really is a make or break year. And the interviewer, who was convinced of it, also pushed back and say, well, what about all these competing priorities for 2021? And I think that's exactly the mindset we need to break, that nutrition does not compete with our other development priorities. Nutrition is foundational in achieving all of our development priorities. And I think this series and the conversation we've had today really, to me, provides both the evidence and a burst of enthusiasm that we really can live up to our promises for nutrition of moms and kids across the world in 2021. Thank you, everyone, and back over to you, Ellen.
Thank you so much, Sean. It looks like we're at time, so I'd like to take this opportunity to thank all the co-authors and panelists for the excellent presentations and the stimulating discussion. A special thanks also go to the event co-sponsors for making this launch possible, and most of all, thanks to all of you for joining this session from around the world. The papers you heard presented today are available on the Lancet website. The email you received today before this event began also has a link to a website with background information, the press release in multiple languages, and other helpful material. Please bookmark that page because we will be posting the slides from today and any new materials there in the coming days. So I'll close by saying the following. We all have a role to play to address the unfinished maternal child undernutrition agenda. We have the knowledge and we have the tools. The time to act is now. Thank you all very much for participating.